It's time to work now. We respectfully invite you to quickly settle down in the auditorium so that the afternoon section can begin right now. Kính thưa quý lãnh đạo, quý khách mời cùng các anh chị hội thảo viên thân mến, đã đến giờ làm việc. Xin trân trọng kính mời quý vị nhanh chóng ổn định chỗ ngồi để trong hội trường để phiên làm việc buổi chiều nay xin phép được bắt đầu. This afternoon conference program includes four presentations in orthodontic, periodontic, pediatric, and endodontic, promising to bring much knowledge and professional experience to the conference participants. Buổi chiều nay, chương trình hội thảo bao gồm 4 bài trình bày về lĩnh vực chỉnh hình răng mặt, nha chôn, răng trẻ em, chữa răng nội nha, hứa hẹn sẽ mang đến nhiều kiến thức và kinh nghiệm chuyên môn cho các hội thảo viên. We would like to respectfully introduce the chairman of this afternoon session. Ban tổ chức chúng tôi xin trân trọng giới thiệu ban chủ tọa phiên chiều nay, Dr. Phạm Tiến Hiển, Head of Periodontic Department of the National Hospital of Odontostomatology in Hồ Chí Minh City. Bác sĩ chuyên khoa 2 Phạm Tiến Hiển, trưởng khoa nha chôn. Dr. Trần Thị Anh Thư, Head of the Endodontic Department of the National Hospital of Odontostomatology in Hồ Chí Minh City. Thạc sĩ bác sĩ chuyên khoa 2 Trần Thị Anh Thư, trưởng khoa chữa răng nội nha. We would like to invite the chairman to begin to work. Chúng tôi xin kính mời ban chủ tọa bắt đầu làm việc.
Phiên làm việc chiều nay là bài báo cáo về lĩnh vực chỉnh hình răng mặt của bác sĩ Tony Collett và bác sĩ Lintenas với đề tài chúng tôi đã gặp rắc rối và cách chúng tôi khắc phục. This afternoon session is open with an orthodontic presentation by Dr. Tony Collett and Dr. Lintenas on topic we got into trouble and how we recover. Còn chúng tôi xin tóm tắt lý lịch của các báo cáo viên. Anthony Collett là nghiệp là bác sĩ chỉnh nha và ông có bằng tiến sĩ và có chứng chỉ của IUB và ông được Hiệp hội Chỉnh nha Úc trao giải thưởng phục vụ xuất sắc danh hiệu thành viên dinh dưỡng. Vị trí hiện tại của ông là trưởng khoa chỉnh nha đơn vị nha khoa chuyên khoa sức môn bệnh viện Monash, giảng viên lâm sàng Đại học Melbourne, ban biên tập tạp chí chỉnh nha Australasian và đăng ký hội đồng chỉnh nha Australasian, giám khảo chương trình sau đại học của Đại học Melbourne và chứng nhận của Hội đồng Chỉnh nha Úc. Ngoài ra, ông đã từng đảm nhận vị trí chủ tịch và ủy ban điều hành của Hội Chỉnh nha Úc. Vị bác sĩ Linton Nash, nghề nghiệp là bác sĩ chỉnh nha, giải thưởng nha trị xuất sắc của Hiệp hội Nha khoa Úc năm 2021. Giải thưởng này có ông đi rộng khắp nước Úc và chỉ được trao 5 lần trong lịch sử. Vị trí hiện tại của ông là bác sĩ chỉnh nha tại phòng khám tư nhân Nash, bác sĩ chỉnh nha cung cấp tại trung tâm y tế Monash, ủy viên hội đồng chi nhánh Victoria của Hiệp hội Nha khoa Úc, nhà phê bình của tạp chí Chỉnh nha Úc, giảng viên dinh dưỡng và tư vấn cho ba em. Và bây giờ kính mời bác sĩ Tony Collett và bác sĩ Lintenas bắt đầu bài trình bày chúng tôi đã gặp rắc rối và cách chúng tôi khắc phục. Trân trọng kính mời. And now, Dr. Tony Collett and Dr. Lintenas, please start your presentation. We got into trouble and how we recovered.
Thank you. I'd like to thank the National Hospital again for the opportunity to visit, and I also would like to thank all our Vietnamese colleagues for their wonderful generosity and hospitality over the last week to myself and our team. Thank you. So our topic is a joint presentation with my colleague Dr. Linton, and Dr. Linton has done some preparation of the slides that I'm actually a little bit unaware of. So for some reason he's added old guy here.
But I had to put myself in as the young guy.
However, careful examination would reveal a full dentition and not too much recession for an old guy.
And I've definitely got some grey hairs. So Tony, do you think you should go first or should I go first?
Well, let's see how we go. Maybe I'll go first when I get this working.
Well, I definitely think age before beauty.
So another title of our talk could be Welcome to My Nightmare in Orthodontics. This is a 1970s and 1980s singer, and the redback spider, if you'd like to see redback spiders, you can just visit my place, I've got a lot. So I'm going first, and I work at Monash Children's Hospital, and I have been teaching orthodontics at the University of Melbourne for 32 years. And one of the things about the University of Melbourne with the students is there's two things. They make me feel quite inadequate with their knowledge, but also keeps you on your toes and keeps you sharp. How do you think with this? Just excuse me. Okay. So we go. Sort that out. Okay, thank you. I think. Thank you. So I'd like to introduce this patient, Nadia. And Nadia is a young lady, and she presented with some crowding of the teeth. One thing we noted was the deciduous canines were present, and I couldn't palpate the permanent canines. Mostly when the canines are ectopic, they are in the palate. So generally, does this have a pointer, Dr. Linton? Pardon?
Doesn't work on the screen.
Okay. So we have a permanent canine. They generally will sit here and here. So we get the OPG, and we can see that there's some ectopic canines. But we need to get a better look. The OPG is not really good enough. So we get the CBCT, and we can see that the canines are sitting labially on top of the lateral incisors. But this is a very unfavourable position for us as orthodontics to retrieve the teeth. Nevertheless, we proceeded to have the teeth exposed, and we designed the initial mechanics with these springs. So there is not only retraction, but there is also an outward force as well, as we try to get the canines away from the roots of the lateral incisors. And we're going pretty well. Things look like they're travelling okay. Now, time for another CBCT. And I discussed the CBCT with the periodontist, and it was decided that there was very little bone on the 1-2 and 2-2. The periodontist felt these had a very poor prognosis, and it was probably best to remove the 1-2 and 2-2. And there was still concern with the lack of bone and coverage of the 1-3 and 2-3, but he felt the 1-2 and 2-2 definitely should go. So, if we could go to the next slide, please. So this is a very unfavourable extraction pattern, but really what choice do we have? So it's time to extract the 1-2 and 2-2 as well. Thank you. Next slide, please. And we took out the 3-5 and 4-4. So the aim is to now close the spaces. And closing the lower spaces is not too much of a difficulty because they're the most favourable orthodontic extractions for the lower arch anyway. But now to close the 1, 2 and 2 and 2 spaces presents some degree of difficulty. Thank you.
So, Tony, you've taken out the upper laterals and lower premolars. How do you get out of this? It's a case where now you've got multiple teeth that are missing that you really didn't want missing in the first place.
Well, next slide, please. We've got the OPG. So the first thing to look at is we're going to do canine substitution. So we're going to place the 1, 3 and 2, 3 to act as lateral incisors 1, 2 and 2, 2. And this is the most conservative option and the best long-term prognosis for the teenage patient. The other concerning factor is the lack of bone over the 1, 3 and the 2, 3. Thank you. Next slide, please. We need to control the torque of the 1, 3 and 2, 3 while closing spaces. This is very difficult because as you close spaces with anterior teeth, as orthodontists will know, as you close spaces, the teeth will upright. If you use full thickness wires, you have too much friction, you can't close the space. If you close the space, then you've got to pay the price of some uprighting of the teeth, which you come and correct later. However, I can't afford to have any uprighting of the teeth, so you start having to think a little bit laterally. You start having to sort of look outside conventional orthodontic mechanics and start thinking about what you can do to control this type of unfavourable orthodontic side effect of the tipping of the teeth. Thank you.
So, Tony, what mechanics did you use to achieve that?
Well, I went back to the 1950s.
That's a long time ago, well before I was born.
Not long before I was. Not that I can remember the 1950s, but anyway, I placed what's called a beg talking archway. And this was placed as an overlay, so it sits outside the conventional base archway that goes into the twin brackets, or the self-organic brackets. And I bent up palatal root torque springs into this archway. So it looks like this. So we have the elastic chain closing the spaces, and we have these torquing springs sitting on an overlay wire outside the main wire. So the spaces can still close on the main wire, and the outside wire, which is applies the torquing springs and keeps the palatal root torque on the upper canines to avoid that unfavourable tipping where we just end up losing more labial support. So it's going okay actually, it was travelling okay, and both the OPG and the supplementary radiograph actually looks pretty good. The torque control has actually been quite favourable. So we got to here, and it's all going quite well. And in fact, I've got to say that when I had the 1, 2 and 2, 2 extracted, this occlusion is actually better than I thought I would be able to achieve. And so we were able to deband with almost centerline symmetry, and actually quite a nice occlusion that will settle in, and that will settle quite favourably. So I think what we've done the patient a good service. We've had to have the 1, 3 and 2, 3 out anyway, or orthodontically positioned, because believing them in that position they can cause long-term damage. I think it was still the right treatment to do because surgical removement of the 1, 3 and 2, 3 as an initial procedure carries a high risk of morbidity to the 1, 2 and 2, 2 in any case. We could have ended up losing 4 teeth rather than just 2 teeth. So I'd like to thank everyone for listening to me. I will hand over to my younger colleague, Dr. Linton, and we'll go from there. Thank you.
So, in honour of Women's Day, most important women in my life, my daughter Penelope and my wife Aurora. So, really, what I'm here to do and what I'm going to present to you today is a case that was very challenging. It was challenging not because of anything that we necessarily did, but because the patient had a very poor outcome. And what I want you to take away from this is how to plan properly so that even in cases where things are going bad, you end up with a good outcome at the end. So this is about that combined planning between orthodontists and surgeons. So, lovely lady came in, class 2, skeletal and dental. Quite a bit of crowding in the lower, little bit of crowding in the upper. OPG showed nothing significant, except she did have some root resorption. Previous trauma, quite significant root resorption, those incisors, but orthodontically this can be managed with careful orthodontics. LATSEF showed a class 2 relationship, but otherwise things looked relatively normal. So, braces on, line everything up, she's ready for class 2 surgery. Now, we're not just going to send her for surgery, we're going to go through our due diligence and our planning. And this was back in 2010. In these days, we did paper tracing. So, trace out where she is, and trace out where we planned her to be. And we have all the surgical movements documented there in the tracings. What's very good is we actually achieved a very nice result, and the surgical plates and everything looks quite stable. And while there's still a little bit of root resorption, overall things looked pretty good. We're happy with the extra-oral result. We took all the braces off.
First up, Dr. Linton reckons this looks like me.
That is Tony, right? Just in his younger days.
He's captured me maybe spiritually rather than physically. Anyway, that's a nice case, Linton, so it looks like we're done. You didn't really have too much of an issue here. There's a time for afternoon tea.
Almost, except the biggest problem with this case was not in the initial treatment or in the initial planning. The problem for us came after we actually finished. About 6 months after the table took all the braces off, she came in with severe jaw pain. At this time, she was referred to oral medicine, and they did a full blood count and a full assessment, and they actually found that there were no problems with her. And they said, look, it's just jaw pain, don't worry, we can't find anything here. Over the next 6 months or so, we had a progressive open bite development. The mandible had actually started to rotate down and back, and the patient ended up with quite a severe open bite. So the initial treatment was quite successful, but we had significant complications post-treatment. This was us about that time. So what we'd noticed at this point is the condyles had begun resorbing, and this is a condition known as idiopathic condylar resorption. It happens, thankfully, very rarely. This is the only case we've ever treated that I've seen. Tony has got one case that he's treated. It's generally a once-in-a-career thing. That said, it does happen, so it's worth being aware of. It happens mostly in young females, oral contraceptive pill, so it's nicknamed the cheerleader syndrome. So remember your cheerleader faces. For this sort of thing, where there is that idiopathic condylar resorption, you have to wait a long time before you can treat again. There is no point trying to treat these cases while the jaws are still resorbing. So from 2010 through to 2019, we actually didn't do anything. We reviewed the patient pain management. In 2018, we sort of started the ball rolling again. Now, no braces on, but we get a full set of records. We get technesium scans, and this is a CBCT to make sure that there is no further resorption of the condyles. And we actually undergo full planning. So I do a Kessling setup, and we combine that together with some ideas of some orthodontic surgery. So whether we do a 3-piece Lafort or whether we do segmental mechanics, we kind of came up with some different surgical plans before I'd even put the braces on. Once we realised, okay, these are the mechanics we need to do. We can't take out the upper fours and close the space orthodontically because there is too much root resorption. We can't close that space predictably to get enough overbite with orthodontics alone. There can't posterior impact. We settled on a plan, and then it was our job to enact that plan. So, again, quite a bit of root resorption, but we sort of, at this point, we were ready to start treating the patient.
I'm a bit concerned about the root resorption, but continue. That would frighten me a little, but glad it's your passion.
Yes, the level of root resorption here absolutely terrified me, and that was a key motivator in kind of what we need to do from here. So the plan needed to come up with something that was safe for this patient and safe for her jaw joints and safe for her teeth. So we decided we needed to take out some premolars, but not initially in the upper because retraction with root resorption orthodontically would have essentially erased those front 6 teeth. So, braces on, lining everything up. Closing some space, making sure there's no further root resorption. This x-ray was taken about 6 months into treatment just to make sure we hadn't made anything worse. It was an opportunity for us to change the plan if needed, but it all looked like it was going well. We keep going, and her overjet is really starting to express itself. We get to the point here, and I'm quite annoyed about the torque of these incisors, but torquing movements orthodontically is one of the most difficult and root resorption creating movements. So we actually left these teeth relatively passive throughout the whole treatment to minimize the amount of root resorption, especially considering we had trauma and build-ups on these teeth. It was something we decided could be managed more prosthodontically at the end. Continuing to close space in the lower, and at this point, we plan again. So I plan orthodontically using model surgery, do a scan of all the teeth, digitally cut them up, squish them all together, make sure things can fit. Once I'm happy as an orthodontist, I send that to my surgeon, and they do the surgical equivalent. So CBCT or CT scan, and just start to move things around. We design the jaw replacements and the maxillary procedure, and it all seems to go very well. The patient has the plates placed. Actually, it was a 2-step procedure. The maxilla was done first, and then about a month and a half later, we carried out the mandible. Now, this wasn't ideal, and we didn't get a textbook ideal result, but we got a very good result. So profile-wise, she's very happy. She's got a jaw. Orthodontically, we still have black triangles in the anterior. We still have differential crown heights. There's still torque issues with the upper incisors. But these are things we planned for right at the beginning. Posterior crossbites were unavoidable in this case. We looked at doing a horseshoe osteotomy to overly expand the posterior, but it would have led to greater risk. Orthodontically, I couldn't push those teeth buccally anymore, so we decided to have a functional posterior crossbite. And this is something that we'd planned from the beginning, and it was that kind of careful planning together and actually planning the case effectively 3 times. We did the original plan, and then we had the condylar resorption. We re-planned again prior to starting anything. And then we planned for a 3rd time where we got the teeth finally looking like this. These are the various things I do, but more importantly, I think it's time for me to have a bit of a tea break at last.
Well, let's make a closing remark. One of the things is the unexpected happens. Unfortunately, not commonly, but you have to be prepared to plan for it. And the human brain is very good at going down a certain pathway. So when you are planning and you have an unusual case, talk with a colleague. Don't rely on your own planning. Always try and get an opinion from a colleague because they will see it from a different viewpoint, different angle, and together you may come up with a better plan. I would like to say that I had thought of the big talking spring idea by myself, but my colleague previously had presented something similar. Dr. Neil Pinto, who's in Wagga in Australia, had presented it, and you got some pictures of from a 1950s textbook, and I used his idea or his presentation as the thought bubble to design the mechanics for my patient. So when you get caught with these unusual cases, I think it is essential to have a discussion with a colleague to come up with the best plan. Thank you.
Cảm ơn bác sĩ Tony Collette và bác sĩ Lê Thị Nát về phần trình bày mà tôi gọi là song tấu, rất là thú vị và vô cùng hấp dẫn. Thì xin kính mời bác sĩ chuyên khoa 2 Trần Thị Thư, trưởng khoa chuyên răng người nha, thì mình thay mặt Trung ương lên trao điểm chương cho hai bác sĩ. Thank you, Dr. Tony Collette and Dr. Lê Thị Nát for your extremely engaging presentation. We would like to invite Dr. Trần Thị Thư, Head of Endodontic Department of the National Hospital of Medical Surgery for Specialty, with Geoffrey, Dr. Tony Collette and Dr. Nas. Thank you. Các bạn quý là on the topic the misbehaving central incisor. Chúng tôi xin giới thiệu tóm tắt lý lịch của báo cáo viên của ông là chuyên gia nha chu. Vị trí hiện tại của ông là bác sĩ nha chu hành nghề tư nhân, giảng dạy và giám khảo tại Đại học Melbourne, ngành răng hàm mặt. Chức vụ trong 10 năm qua của ông là đội ngũ giảng viên thường trực tại Đại học Melbourne, phân ngành cử nhân sức khỏe răng miệng, cử nhân khoa học nha khoa và chương trình bác sĩ răng mặt được đào tạo cho nước ngoài.
Thank you to the organising committee for inviting me, and to Dr. Hien and the periodontics department have been brilliant this week. Very, very professional department, so thank you for having me around. So my talk is basically on, I guess, the diagnostic aid of having teeth that starts moving around. So I predominantly work in private practice, so I see a lot of sort of severe, moderate to severe periodontal cases. And one of the most common complaints to me is the patient sits down in the chair and ask, why are you here? And they'll point to their front tooth, say my front tooth has been moving. I've just picked the central incisor as an example. It is actually pretty common for that to be moving. Or they might complain that the gap between their front teeth is getting bigger, or the front tooth is actually becoming longer. So while from a periodontal perspective, while they mention one tooth in particular, it often dictates that there is more of a generalised problem. So when a tooth starts to migrate from periodontal disease, it usually has moderate to advanced bone loss. Very rarely will we see a tooth with a mild periodontal condition, sort of drifting. And by definition, periodontitis is two or more sites with interdental clinical attachment loss. So it's, there's more than one tooth involved, basically. So for simplicity, I'm just going to refer to the 1999 classification for periodontal disease at the moment. There was a classification system that was introduced in 2018. The beauty of the 1999 classification is it is descriptive. So we classify it into chronic periodontitis, localized or generalized, aggressive periodontitis, and there are a number of other categories. For example, in the new classification, if I was to write back to a referrer and say this patient has stage 3 grade B periodontitis, if they haven't trained within the last 5 years, a lot of them just don't understand what I'm talking about. So this condition, this classification, for the purpose of the lecture anyway, is easier to discuss. So most of the patients that we see, 99% or more, are going to fall into the chronic periodontitis category. Usually, if we're starting to get teeth moving around, it's probably going to be an older patient, sort of maybe 40 upwards. As you can see, it's pretty obvious when you get a chronic periodontitis case. There's lots of local factors, lots of inflammation, and as I said, you can see some teeth starting to drift around. And it's classified, classic presentation of chronic periodontitis is usually horizontal bone loss. There might be a few sites where there's angular bone loss. And you can see with the periodontal charting, these are two separate cases that the probing depths don't really follow any particular pattern. They're just sort of random. And those little dots on the chart, particularly on the right side one, indicate that there's bleeding. It hasn't been listed on the other chart, but you can see there's usually lots of bleeding on probing when we look at that. So usually a chronic periodontitis case, you look at it without touching the patient and you know it's pretty much going to be chronic. So this is just an example of what chronic periodontitis can do. So we do see teeth moving in these older patients. So this is, for example, a 60-year-old male. And he presented to me, he was a patient at the dental hospital, and he was a little bit on the aggressive side, as his personality was, and he had been bumped around a few departments. He'd seen an endodontist, the referring dentist thought the tooth may be non-vital, so they did their electric pulp testing and confirmed that it was alive. And for some reason, he ended up in the oral surgery department, and they said, no, go and see a periodontist. So his presentation was that he felt that tooth 1-1 had started to drop, and the gap between his front teeth as well had started to open up. He had a bad taste in the mouth, and the gingiva over the 1-1 was tender. And as you can see on the right photo, probably not very well, there is some notable suppuration when palpating the buccal gingiva. So this patient had a generalised condition, as we discussed earlier, even though there was this one tooth was his main problem. So anteriorly, he had a 10 millimetre probing depth with that notable suppuration and bleeding. And the PAs probably don't show it very well, but there is pretty significant bone defect on the mesial aspect of the 1-1, and just the angulation doesn't show it as well. There's some on the distal as well. So interestingly, there's a rule almost with teeth that migrate due to periodontitis, is that they usually migrate away from the bone defect. So if you've got a defect on the mesial, the tooth will actually drift to the distal. So the defect's on the mesial, the tooth will drift away from it. And we see that pretty much in every case that presents to us. So if someone presents to me with a localized problem and the tooth has drifted, I can pretty much tell there's going to be a bone defect on that surface it's moving away from. So in this case, we did some non-surgical treatment, and there was still a persistent probing depth on the buccal of the 1-1. So we decided to raise a flap and have a look what was going on. 10 millimetres is a pretty significant pocket. That's almost down to the root apex. So we raised the flap, and you can see there is quite a lot of granulation tissues on those mesial and distal bone defects. And You can probably see at the apex of the tooth there is a fairly significant calculus deposit right near the tip of the root. So the photo on the right shows we've degranulated all the area, that's all been cleaned out, and all that calculus has been removed from the root surface, and we're pretty much right on the root tip. So in this case, we decided to utilise a regenerative approach. So I know this is something the periodontics department here is very interested in doing a lot of. Basically use the regenerative material MDOGAIN. So that's derived from developing teeth germs in pigs. So we applied that to the root surface and closed the flap. So after 12 months later, you can see there's been a little bit of recession on the tooth, maybe 2 millimeters or so. The probing depth's within the normal range, and the tooth hasn't moved at all. It's been pretty stable. So normally we find with these teeth that start to move a bit, once we've treated the periodontal condition and stabilised the gum condition, it doesn't really tend to move. Okay, so we've been sort of focusing on sort of older patients. This is a younger patient that was, I think she was in her early 20s from memory. And she presented complaining that her upper central incisors had started to move buccally. They did feel a little bit loose as well. So if you look at the mouth, generally speaking, there's not too much inflammation, apart from on the palatal view where you can see that gingival margin looks quite inflamed. The fixed wire that was there, interestingly, she had a course of orthodontic treatment, and then the gap started to open up again. So she had another course of orthodontic treatment, and then she had that wire placed. But anyway. So you can see from the periodontal chart, this follows a very distinct pattern. So we've got deep probing depths predominantly affecting the upper incisors and also the first molars. So when you see that type of thing, minimal clinical inflammation, this sort of pattern, we can usually confident in making the diagnosis of a localized aggressive periodontitis. So you can see on the radiographs significant bone loss between the centrals and also angular bony defects on the molars as well. So that's pretty diagnostic. This is another localized aggressive case that I saw probably in the last 6 months or so. The patient presented with the 2-1 starting to drop a little bit, and it also felt a little bit loose. So you can see from the radiograph there's really significant bone loss. It's almost complete loss of the buccal plate there. And on the radiograph, similar type of thing. We've got some pretty significant bone defects affecting the first molars. And also similar pattern affecting the incisors and first molars. For a patient that's in their mid-20s, probing depths up to 8 or 9 millimeters around these teeth, that's pretty diagnostic. Sorry. I should mention the treatment for the reason why we're interested in ascribing a proper diagnosis is that the management is probably a little bit different from a chronic periodontitis patient. So with a chronic case, they usually respond quite well to conservative management, which is scaling and root debridement, either quadrant or half-mouth approach under local anaesthetic. With these aggressive patients, from experience, I have had the opportunity when I was going through my postgrad training to treat a number of these cases. They really do require some systemic antibiotics in conjunction with the treatment. So the gold standard used to be a combined course of amoxicillin and metronidazole. Quite often these days we also use azithromycin as well. So it is important to get that diagnosis. I have treated these cases without systemic antibiotics, and usually it takes a very long time for them to heal, and they're far better off with the systemic antibiotics. You can also, because they're vertical bone defects we're dealing with, you can consider surgical approach as well. So the first patient that I put up ended up actually did it on general anaesthetic. We raised flaps around all the T's, instrumented everything, and the regenerative material Emdogain was used in all those sites, and that patient healed very nicely. And the second case that I just put up was just treated non-surgically with systemic antibiotics and responded very nicely as well. So with a generalised case, you're usually not left guessing what the diagnosis is. The patient will often present having lost a number of teeth, and it doesn't really follow a distinct pattern of tooth loss. There is some thinking that the localised aggressive cases can actually then become a generalised aggressive case, but the literature is not very clear in that regard. But the similar type of thing, there's not a lot of local factors there, but there is significant inflammation and very rapid bone loss, vertical bone loss. So this is a case that was seen by one of my business partners actually last year. So without getting too much detail away, the patient came in with generalised periodontitis. There was 5 to 7 millimetre probing depths throughout the mouth, and that PA was obviously taken at the initial examination. You can see there's fairly significant bone loss there. So she went through and treated him, and he was supposed to come back 3 months later, and he didn't. He presented 6 months, coming back 6 months later, saying, "Oh, all my front teeth are starting to feel, really loose." So she took a photo, which I'll show in a minute, and she almost fell off her chair when she saw it. We don't have the pre-op photo, unfortunately. So this patient was, she got onto the phone to the local maxillofacial surgeon pretty quickly. He biopsied it, and the diagnosis was a squamous cell carcinoma. So I don't actually know what his progress is like. He's probably still being managed as we speak at the moment. So some other things that we see, which is a little bit different, which can cause some irritation around front teeth and possibly some tooth movement, is we can see in this radiograph here a cemental tear. So a piece of cementum has detached from that 1-1. So you can see there's a mesial bone defect there, and that has migrated coronally. So that almost acts as like a foreign body in the soft tissue. So these cases sometimes are a little bit tricky to treat. We find that removing the fragment, having a really clean root surface, is often enough to stabilise things, but we never give the patient a guarantee with these types of lesions because we don't know exactly how it's going to fare long term. But my experience has been once the fragment is removed and the root surface is clean, the tooth is usually okay. So this is another cemental tear. So this patient had generalised sort of moderate to severe periodontitis, and you can probably see on that 1-1 there is a little fragment, and that is also another cemental tear. So that was easy to treat. It was just closed non-surgical debridement under local anaesthetic. I was able to tease out that fragment through the gingival margin area, healed nicely, no more problems. So the issue with this type of thing is when these patients present, particularly some of these patients, I must add, go directly to orthodontists. I've had a number of orthodontists refer these cases saying they come because their front tooth is moving, and it's actually not orthodontically related. It probably is some contribution from the malocclusion and parafunction, but there's often the underlying periodontal condition. The issue with these is once the tooth is stabilised, it's not going to move back into its original position. Interestingly, I have seen a few cases that have actually they've had mesial or distal rotation, actually gone back into their original position. But this type of thing, when you've got a super-erupted incisor, that's not going to correct itself. So I treated this patient 7 or 8 years ago. She fell off the radar, and particularly through COVID, and just came back recently. Been no change whatsoever in the position of that tooth. So I actually referred her off for an orthodontic opinion, but from my understanding, orthodontists are not very keen on intruding these types of teeth. So we'll see what the outcome is. You might be looking at a tooth replacement. But I think what I have experienced is a lot of patients come to us with the view that they want to fix the appearance of their teeth. So we need to be upfront with them at the start that we can stabilise their gum condition, but they may not actually be able to correct that tooth without removing and considering replacement. So as I mentioned before, this is the 2018 classification, which I'm sure most of you are familiar with. As I said, it's not particularly descriptive in correspondence anyway. So usually in my correspondence now, I will say this patient has generalised moderate to severe periodontitis, and in brackets I might put stage 3, grade B, for example. So most of these severe cases that we've seen would fall into at least the stage 3 or stage 4, where there's a number of clinical attachment loss of 5 millimetres or more between a number of teeth, and bone loss to the middle or apical third of the root. And then the grading. So usually a chronic periodontitis case will probably fall into the grade B category, which is a moderate rate of progression. The aggressive periodontitis cases would probably fall now into grade C, which is a rapid rate of progression. And note the two main modifiers of periodontal disease is either smoking and diabetes, so that can influence the grading that's been done. This system also allows for the use of blood tests and biomarkers to be included. We routinely are not doing that at the moment. In future, I mean, there's been a lot of work being done at the moment on biomarkers and whatever, but at the moment we're not really utilising that well. But the system has been designed so that that can be utilised. But yeah, that concludes the end of my presentation.
Cảm ơn bác sĩ Mark Palmer về bài trình bày tuyệt vời. Và kính mời bác sĩ chuyên 2 Phạm Tấn Hiển, trục Nha Chu Từ Liệt. Mình lên trao kỷ niệm chương cho bác sĩ Mark Palmer. Thank you, Dr. Mark Palmer, for your wonderful presentation. Would like to invite Dr. Phạm Tấn Hiển, Head of Periodontics Department of the National Hospital Odontostomatology in Ho Chi Minh City, to give a topic to Dr. Max Palmer. Học Griffith và Đại học Western của Australia, và hiện tại ông là tham vấn cao cấp về răng trẻ em tại Bệnh viện Nhi Perth. And now, Dr. Gregory Redford-Zilling, please begin your presentation where medicine and dentistry meet.
Thank you very much. Thank you to everyone at the National Hospital for Odontostomatology for having me, and thank you Tony and the Rotary team for having me back again this year, and Dr. Woman for the Pediatrics Department. Today I'll be talking to you about where medicine and dentistry meet. Just some examples of some cases or some places where pediatric dentists are involved in patients who have medical complexities, medical issues, and where dentistry and medicine overlap. So this is where I'm from. I'm from the state of Western Australia. Western Australia is the largest state in Australia. It makes up nearly half of the continent. It's 2.6 million kilometres. And we have about 2.6 million people, most of which live in the main city of Perth, which is where I live. The dental department at my hospital, at Perth Children's Hospital, we have almost all of the dental specialties working there, except for an endodontist and a radiologist. And that is more than 20 people working together. We also have trainees. We have residents or registrars working there as well. One of those is a registrar for oral and maxillofacial surgery. We have 5 registrars in pediatric dentistry. We have 2 service registrars who are junior dentists learning pediatrics as well. Our dental clinic, we have 5 chairs in our dental clinic, but that's not the only work that we do. We also spend 2.5 days of every week in the operating theatres doing dental treatment under general anaesthetic. We do emergency cases and also cases under general anaesthetic in cooperation with other medical and surgical teams in the hospital. We treat emergency patients in the emergency department itself. The hospital has 10 wards where we have inpatients staying in the hospital, and we service those wards as well. We also have 2 day treatment units where patients attend the hospital just for the day to get medical treatment, and we will attend those clinics as well as patients being seen in the medical imaging suites. And then we obviously also have multidisciplinary or interdisciplinary meetings where we sit with some of our dental or medical colleagues to discuss patient treatment planning. The first types of patients that I would like to talk about is patients who have orofacial clefts. Our hospital, Perth Children's Hospital, is the cleft lip and palate centre for our state. And so as paediatric dentists, we play a big role in looking after these patients. This is just an example case to go through of a patient born with the right unilateral cleft lip and palate, complete cleft lip and palate. Clefts obviously come in lots of different forms, different shapes and sizes. No 2 clefts are ever truly the same. There are lots of different classifications that are used for clefts. Some of them are more useful than others. We tend to use a fairly descriptive classification. We find that makes communication easier between departments and allows for a little bit more flexibility in understanding some of the smaller differences between some of the patients. In our hospital, we don't do a true nasolabial molding, but we still do pre-surgical orthopedics. I know in a lot of centres, and including here at the hospital, that's traditionally done by the orthodontists. But in my hospital, that's done by the paediatric dentists. So my team of people who do the pre-surgical orthopedic treatment. And so this patient has had their pre-surgical orthopedics to bring the segments a little bit closer together in preparation for their lip repair. So when these babies are born, the paediatric dentists are often the first people to see the patients once they've arrived in the hospital. Often the early cleft treatment is usually outlined by the lip repair and the palate repair. But from that period onwards, often the paediatric dentists are the people who see the patients most, because we will see the patients every 6 to 12 months for regular routine dental reviews. We will monitor to see if they develop any caries. We'll do routine preventative work. The other thing is that this is the age group between when they start to get their teeth and 3 years old and they finish getting their primary dentition. This is when they first develop their dental anomalies related to their cleft. So this is the time when the parents often have lots of questions about why their child's mouth doesn't look the same as all the other children. And so we play a very important role in identifying with those parents the things that they can expect to see. And we continue that engagement and desensitization of the patient coming into the hospital as well. Often for these children, visits to the hospital are not a pleasant experience. So having routine and easier visits for them often does help things in the long term. As the patients age towards 6 years old, they start to head towards the early mixed dentition. At this stage, they have often not yet seen the orthodontist, so again, when their mouth starts to change as they transition to the mixed dentition, we often deal with a lot of the questions and concerns that parents may have, as well as identifying issues or concerns that we may have or need to identify that might need management or some guidance. Again, we're still doing routine checkups, routine preventative dental care, restorative dental care, and providing these patients with the opportunity to maintain the best oral health that they can, because that plays an important role, as we know, in all of their clinical care. The concept of a dental home is one that's advocated by a lot of sort of international organizations, including the American Academy of Pediatric Dentistry. And they advocate for patients having somewhere that they identify as their dental home that they can attend with all their issues, that's somewhere familiar to them, so they're not seeing someone new every time, and they're more likely to go and see the clinic or see the hospital on a routine basis rather than only when they have a problem. Usually around 9 years old, often patients around this time are starting to face the prospect of an alveolar bone graft. The planning for alveolar bone grafts obviously can be quite complex, and this is a very interdisciplinary process in our hospital. It requires involvement from pediatric dentists, orthodontists, surgeons, speech pathologists, and generally we will have a scheduled meeting every 2 to 4 weeks, where we sit and discuss all the patients who are approaching the time for alveolar bone graft. Any clinician in the department can identify a patient earlier than they come up routinely. If they may be developing ahead of time, their dental age or the root development of their teeth may be ahead of their chronological age. And then we present these patients in a surgical plan or a plan around the alveolar bone graft. It's formulated by the department as a whole and has to be signed off by all of the different specialties involved before the plan is implemented in place. We feel that it's important for the pediatric dentist to be involved in this process because often we are the people doing a lot of the work before the bone graft surgery itself. If the patients have caries that needs to be treated, that's the job of the pediatric dentist. If they need extractions in the dental clinic before their bone graft surgery, that's often the job of the pediatric dentists. So it's important that we're involved in that process, but no one person or one specialty can ever plan something this complex. It requires input from everybody. As well as that, our surgical teams for alveolar bone graft and for our cleft surgeries is a combination of maxillofacial surgeons and plastic surgeons as well. And when the plastic surgeons are involved, sometimes the dentists are required to attend to remove teeth from within the cleft or to place a splint at the end of surgery to stabilize the segments after the graft is placed. Through adolescence, there tends to be a lot more involvement, obviously, with the orthodontists at this stage, as they develop the rest of their permanent dentition, as they go for alignment and preparation for if they require orthodontic surgery. Again, as with all the other age groups or times in this patient's development, we need to maintain the patient's good oral health, making sure we're keeping them on a good preventive regime, making sure that they're looking after their teeth properly and doing any treatment that they need. Restoring any carious lesions or anything like that. And again, often patients may need orthodontic extractions, which are still done by the pediatric dentists. Then when the patients finish adolescence and reach their early 20s, often they will have their orthodontic surgery and any orthodontic treatment completed by the orthodontists and the maxillofacial surgeons. Often any final restorations may need to be placed, are still placed by the pediatric dentist at this stage. Because our hospital is a children's hospital only, these patients only stay with us until they have finished their main treatment through their adolescence. Once they've finished all their surgeries, once they've finished all their other dental and orthodontic treatment, then they have to transition to an adult hospital. And so it's one of the jobs of the pediatric dentist to guide that transition to adult services so the patient can go to a different hospital to be looked after as adults. Sometimes it's difficult to remember the whole journey of a cleft patient. You see some of them as babies, and you see some of them as teenagers, and you see some of them as adults. Sometimes it's good to see a patient from where they started all the way until when they finished. Now we're going to take a slightly different look now at childhood cancers. Our hospital, the hospital where I work, is not just a dental hospital, it's a medical hospital as well. And so we look after all the patients who have childhood cancers. Some of the most common cancers that we see in childhood include things like leukemias, lymphomas, neuroblastomas, which are particularly nasty type of cancer, brain tumours, sarcomas, which affect often the muscle and bone and connective tissue, and Wilms tumours, which are a common childhood cancer affecting the kidneys. And you might wonder what role the dentist can play, particularly during management of childhood cancers, given these are not oral cancers. But the reality is that the way that childhood cancers are managed still usually involves chemotherapy. It's quite rare to have radiotherapy to the head and neck in children because the side effects are very severe on the brain. But all these patients who are having chemotherapy are immunosuppressed, so they have often no immune system, and as well as that, they can suffer from mucositis, which is inflammation of the gums, the buccal mucosa, all the tissues in the mouth, and it can be incredibly painful. And so we need to assist with pain management, particularly if they require topical pain management, on top of obviously their routine dental and oral health care. And then for patients who require dental treatment, because often when they start their treatment for their cancer, they may already have caries or other dental issues that need to be dealt with, then we have to be able to provide routine dental care to patients whose immune system is compromised, and they might have neutropenia, so lack of white blood cells affecting their immune system. And they may also have a lack of platelets, which could cause a bleeding issue in many patients who require dental extractions. As well as dental treatment provided during cancer treatment, these patients often will have long-term effects from their cancer treatment. So there are some chemotherapy agents that even some of them are very old, a lot of them are still used very commonly in childhood cancers, and they can have effects on the growing dentition. Usually the at-risk age group we see this is children who are up to the age of 6. If they have chemotherapy agents given before they are 6 years old, they can suffer from a few different anomalies. These are small films, but this is the same patient 2 years later, and he highlights some of the issues that you can see. A very common one is tooth agenesis, so any teeth that have not yet started to calcify will never develop, and so they effectively become patients who have oligodontia, or patients who are missing a lot of teeth. They can have microdontia, so some teeth that maybe have only just started to develop might still develop but be very, very small, and probably too small to be useful teeth. They can get hypoplastic defects, so like enamel defects that affect the teeth, that may require restoration as the patients get older. And some teeth, if they're busy developing their roots, even if the crown has finished calcification, then you can have the root development stop before it finishes, before the root has gained its full length, and that leads to the teeth having a very poor crown to root ratio. And in a patient like this, in fact, all of the primary teeth are mobile, and that's not due to the erupting permanent teeth. There's just a very poor crown to root ratio in all of those teeth. And so as pediatric dentists, we have to try and guide these patients as well as we can to get what teeth they do have developing into the mouth, but they require, again, interdisciplinary planning because these patients will need prosthetic rehabilitation in the long run, and that can never be done again by just one team. This is just another example of the same thing again, but in a patient who is a little bit older, so they've got a few more teeth. They're still missing canines, missing their permanent canines in both the maxilla and the mandible, as well as premolars, and you can see some defects. If you have particularly a look at these lines in the teeth here, it's where there's been a short cessation of tooth development, of calcification, and that causes a hypoplastic defect in the teeth that will need to be managed once those teeth are sufficiently erupted. Like I said, it's quite rare for us to treat patients who've had radiotherapy to the head and neck in children, particularly in younger children. The effect on their brain is very severe, so they'll only usually do that if it's required as part of their sort of life-saving treatment. This is just a quick example of an older patient we had who was in her mid to late teen years, and she had a cancer to the right side of her throat, and so she had to have radiotherapy for that cancer. And then not very long after she had finished treatment, she needed a tooth extracted because it was unrestorable. Thankfully, the tooth was in the maxilla, which is much lower risk, and we were able to map the radiation therapy that she had had. And thankfully, the tooth was outside of the sort of high risk zone for radiation. It's worth pointing out as well, usually oral maxillofacial surgeons are much better placed for planning these cases, so again, we don't do these cases in isolation. Now, I also said before that we don't usually see oral tumours or oral cancers in children. That is true, but there are some very rare types of cancers that can happen in children. We have some children in birth who are born with a type of tumour, a benign tumour in their mouth. There's a very long name called a melanocytic neuroectodermal tumour of infancy. It's a roughly golf ball sized black or brown tumour that affects the maxilla. But in order to allow the patient to function, obviously the tumour has to be removed, but that results in a defect in the maxilla. Where often the tooth buds are also removed during surgery, as they have to be, and then these patients, long term, will need long-term prosthetic rehabilitation. But we also have to look after the children while they're growing up. The teeth in this case have erupted with very short roots on them, and the orthodontists in our department were not keen to start moving those teeth into place or doing any orthodontic treatment just yet. But the patient is starting school, and so it's important that we do something to help the social issue of attending school while missing a lot of front teeth. And so we have to provide interim prosthetic management that both allows dental development and also psychosocial development at school. We toyed with the idea of different types of designs, an overdenture which would cover the developing teeth, but potentially be more aesthetically acceptable. But we found that obviously covering the erupting teeth probably was not going to be a good idea for allowing development in this case. So we opted rather for a design that leaves those teeth open, also allows for better hygiene and reduces the caries risk for a tooth that already has a hyperplastic defect. That's just the final appliance on the model, and then it makes the patient effectively just look like she has an anterior open bite, which is true, she does. But in this case, it just gives her a little bit more to smile with and allow her to function, and socially allows her to develop at school as well. Just one quick slide again for something that we occasionally see in newborn babies. It's a thing called the congenital epilus of the newborn. This again is usually quite a small benign growth. They occur usually more commonly in the maxilla. They often have a narrow base, and in most cases no surgical treatment is required. We will often monitor them and they will resolve by themselves. But if they don't, or if they're causing any issues with feeding or anything like that, then we'll refer them to our oral maxillofacial surgery colleagues to manage. And then just one more quick case to look at, just some different types of things that we see in the children's hospital in our dental department. This is an example of a 13-year-old girl. Her medical history is only significant for autism. She has no other medical conditions. She does not take any medications at all. She has no allergies that are known at all. Because of her autism, as is quite common, her diet is very limited. She doesn't eat a lot of different types of foods, so she usually only eats chicken, potatoes, and chocolate. She has very poor oral hygiene. She doesn't brush her teeth very often at all. And these lesions have been there for several weeks and bleed very easily, and they tend to break off in pieces quite easily as well. We took a radiograph and there were no other radiographic findings at all. We obviously acknowledge that she has a supernumerary tooth in the upper right lateral incisor region, but there were no other sort of radiographic findings or anything that might relate to a diagnosis for this. There are quite a lot of conditions that can present similar to this, although this is quite a severe presentation. And some of those differential diagnoses are quite concerning, including things like leukemia. Again, we involved not just ourselves, but we got our oral maxillofacial surgery colleagues to give us a hand to resect some of that tissue away. We would have loved to have done blood tests before we did any treatment, but because of the patient's severe autism, we were not able to get blood tests before we had her under general anesthetic to do treatment. So we had to guess a little bit what our differential diagnoses would be. This is her a little bit later, after she'd had treatment. Her oral hygiene is still poor and she still has gingivitis, but obviously it doesn't have that same severe appearance that it did before. Now the question comes up then of what things do you look for, what investigations should you do? And the blood test that we decided to do under general anesthetic was to check for iron showed full blood count, which showed iron deficiency, anemia, but only very mild. There were no other significant findings at any of the blood tests except for one. And that was to look at her vitamin C. So vitamin C is something that is in most modern diets in sufficient amounts. It's a very old condition that we call scurvy, which we don't see very often these days because of the varied diets that most people have. But in the olden days, this was more common. But we looked at the vitamin C level in the blood test, and we found that it was significantly lower than the normal range. And so the main treatment that she had was to see a medical doctor, to start on vitamin C supplements, to take medication to increase her vitamin C. And then apart from her plaque-induced gingivitis, the lesions healed very well. And that's my hospital. We're very lucky. It's a very new hospital with a very nice view across the park. I'm very lucky to work there. But if anyone has any questions, thank you very much.
Cảm ơn bác sĩ Celine về bài trình bày tuyệt vời. Xin kính mời bác sĩ chuyên khoa 2 Phạm Tấn Hiển, trưởng khoa Nhi Trung Bệnh viện Đa khoa Trung ương Thành phố Hồ Chí Minh lên trao kỷ niệm chương cho bác sĩ Gregory. Thank you, Dr. Gregory Celine, for your wonderful presentation. We would like to invite Dr. Phạm Tấn Hiển, head of the Cardiovascular Department of the National Hospital of Neurology and Anesthesia, to give a topic to Dr. Gregory. Kính thưa toàn thể hội nghị, phần báo cáo kế tiếp cuối cùng nhưng rất hấp dẫn, đó là bài presentation. Last but not least is shared by Dr. Luke Vovula on the topic predictable endodontic outcomes. Chúng tôi xin giới thiệu tóm tắt lý lịch của báo cáo viên bác sĩ Luke Vovula, chuyên gia về nội nha. Ông tốt nghiệp cử nhân khoa học nha khoa năm 1999 tại Đại học Otago, New Zealand và tốt nghiệp bác sĩ nha khoa lâm sàng năm 2005 tại Đại học Melbourne. Và hiện tại ông là bác sĩ nội nha thực hành lâm sàng tư nhân và là giảng viên lâm sàng về nội nha Đại học Melbourne. And now, Dr. Luke Vovula, please start your presentation. Predictable endodontic outcomes.
Dr. Tao for the introduction, and thank you to the National Hospital and to the Rotary team for inviting me back to Ho Chi Minh City and Vietnam. This is my second year here. Last year I really enjoyed exploring the city and the culture and meeting everyone at the hospital. I promised Dr. Van An I would talk slower, so if I talk slowly it's because I've promised Dr. Van An so she has time to translate. This year it was really interesting to be taken out to Cu Chi to look at your cultural village and learn about the culture. Dr. Lee, Van An and Tien took me out to sample some of your food, which was an interesting experience. It was also nice to see that some of the things that we talked about last year being implemented in the department, such as the use of Dr. Dan by Dr. Tien. So that makes me feel quite useful, and hopefully some of the message that I'm trying to get across is being accepted. Being the last presentation for the day, I know everyone is tired, so I'm going to try and keep this brief. My message today is very simple. What I wanted to do is to give everyone a simple formula for success in anything that they do. If we look at success, there are three critical things. We have to start with a goal, we have to have a strategy to achieve that goal, and then we have to put that strategy into action. When it comes to endodontics, the goal is very simple. We're trying to prevent bacteria from entering the root canal system, or we're trying to remove bacteria from the root canal system, because we know that bacteria inside the root canal will cause disease in the form of apical periodontitis. Not only are we trying to manage bacteria, but we're also trying to maintain those teeth for our patients, ultimately for the rest of their lives in some cases. The strategy for removing bacteria from teeth is endodontic treatment. And that usually involves eliminating or removing the bacteria by undertaking mechanical and chemical cleaning of the root canal system. It also involves preventing bacteria from re-entering the root canal system in the form of obturation and restoration and providing a seal. Now, it's all well and good having a goal and a strategy, but it's how we implement that strategy and put it into action that's going to make a difference in terms of achieving our goal. So having an understanding of the strategy and the goal in the forefront of our minds is critical to this. And the outcome is going to be affected by many things, some of which are the skill of the person undertaking the treatment, their level of experience, and the equipment that they have available to perform that treatment. Successful endodontic treatment, as I see it, consists of a successful chain of events. If we break any of those events, it creates an opportunity where we may not remove bacteria, or where we may allow bacteria to get into the root canal system. So let's talk a little bit more about the goal. Teeth are in the oral cavity. The oral cavity is covered by saliva. Saliva has millions and millions of bacteria in it. So we're in a predicament because we're trying to deal with bacteria inside teeth, inside the oral cavity, which is full of bacteria. Bacteria get into teeth through decay, through cracks, and through leaking restorations or deep restorations. We know bacteria live in the root canal system and will contaminate the root canal system and cause disease. The bacteria will penetrate into the dentine tubules, and they'll also form layers of bacteria called biofilms, which can be very difficult to disrupt. To add to this, there's many obstacles in us being able to remove that bacteria from the root canal system. The root canal system is not a very straightforward space. There are lots of variations within root canal systems. There are many irregularities, there are many deviations, many branches of the root canal system. Towards the apex, there are little areas called apical deltas, and bacteria inhibit all of those areas. Now, despite all of those obstacles, if we look at the literature, we can find that if we undertake endodontic treatment to a high standard, then we will be able to achieve high success rates in managing infections in teeth. And that can range from anywhere from 80 to 90% in terms of achieving overall healing by reducing or eliminating bacteria from the root canal. And in some cases, we can retain teeth in over 90% of cases. So let's look at the strategy. So we've got the goal in the forefront of our minds, which is to remove bacteria. The strategy is root canal treatment. And root canal treatment essentially has two phases to it. The first phase is instrumentation, which can be broken down to various goals, biological and mechanical. The biological goals that we're trying to achieve is that we want to remove or reduce the number of bacteria in the root canal system. We also want to remove as much tissue that is in the root canal system, tissue that can support further bacterial growth. From a mechanical point of view, we're trying to create a continuous taper within the root canal system from the orifice to the apex. While we do that, we want to maintain the original shape of the canal, and we don't want to change the position of the foramen at the apex. The second goal, or the second phase of root canal treatment, is obturation, and the aims of obturation is to seal the space to prevent bacteria getting in there. We know we don't always remove all the bacteria out of the root canal system, and part of the aim of obturating the canal is also to seal the space to make it hard for bacteria to regrow in significant numbers, and also for that bacteria to have a difficult time trying to gain access to nutrients. So we're essentially entombing bacteria within the root canal system. And usually the obturation is a reflection of how we've instrumented or cleaned that root canal system. So let's break down some of the treatment phases when we're trying to undertake endodontic treatment in teeth, and we'll go into these in a little bit more detail. So everything starts off with the evaluation of a tooth. What tooth are we working on? Is it a back tooth? Is it a front tooth? Does that tooth have 1, 2, 3, 4, or 5 canals? Where is that tooth? Is the tooth going to be easy to access near the front of the mouth? Is it going to be more difficult to access towards the back of the mouth? What's the restoration like in that tooth? Is the restoration leaking? Does it need to be replaced? Is the tooth restorable? Are there other factors like the angulation of the tooth that's going to make it more difficult without access into the pulp chamber? So together with our clinical evaluation, we also undertake a radiographic evaluation. And we do that with conventional radiographs. We use bite wings and we use periapical films. And the important thing I want you to note is if you look at the radiograph on the left and the radiograph on the right, it's the same patient. So taking good quality radiographs will give you quite useful information that will help you plan your treatment. And I find using holders makes things a little bit easier. And if we take a good radiograph, then we're going to be able to use that radiograph to gain quite a lot of information to help us plan that treatment. We're going to be able to assess the restoration, we're going to be able to assess any caries, what the root canal anatomy might be like, how easy the pulp chamber may be to access, are there any obstacles such as curves in the roots or calcified canals. We can get additional information from 3D scans, cone-beam CTs. We don't always do that for every patient, but we do find it quite useful in some cases when it comes to diagnosis and treatment planning. A critical step in endodontic treatment is maintaining an aseptic technique, and this is something that I've been talking to the dentists at the department throughout the whole week and last year. Let me share a quick video with you. And I've shared this with the dentists at the department, I think. So, one of the number one things that dentists often tell me why they don't use rubber dam is time. I don't have enough time during the appointment to place the rubber dam. If we look at this video, the rubber dam was placed in 40 seconds. 40 seconds is not a long period of time to place the rubber dam and make your life easier. The second thing that most dentists say is that I've got patients who can't tolerate the rubber dam. Now, I've been doing endodontics for over 20 years, or almost 20 years, and I've had 5 or 6, maybe 10 patients that couldn't tolerate rubber dam. The majority of the time, patients actually prefer rubber dam. It makes the treatment a lot more comfortable for the dentist as well as the patient. There are many benefits to using a rubber dam. Endodontics, dentistry is hard as it is. Rubber dam makes things a lot easier. It provides for a clean working field. It improves your visibility because it will retract the tongue, it'll keep the tongue out of place, it'll keep the cheek out to the side. So it just makes your whole life a lot easier and makes your treatment actually easier. The 45 seconds you take putting on a rubber dam may save you 5 or 10 minutes of treatment time. It also improves safety. So, patients aren't swallowing hypochlorite. There's no risk of a patient swallowing it or aspirating a file or any of the instruments that we're using during our treatment. Part of an aseptic technique is also removing long restorations. A lot of the time when patients develop pulpitis, it's because those restorations are leaking. And leakage can affect the outcome of your treatment. So this particular patient with the radiograph up the top, you can see was sent to me because the dentist had treated that tooth 3 or 4 times and the patient had persistent pain. And the main reason for that was that there was decay under the restoration. And no amount of cleaning they were doing during the treatment could sort of overcome the fact that new bacteria were getting in between the appointments. And the main difference there was we just removed the restoration, treated the tooth as the dentist has been treating 3 or 4 times, and resolved their pathology problem. Taking fillings out also allows us to assess the restorability for a tooth. It allows us to locate canals, it allows us to find cracks. This is typically the sequence of events that I would go through when temporizing broken down teeth. One of the things my mentor once said to me was the fastest way to do something is to do it right in the first place. So sometimes taking shortcuts, while it may think you're saving time, actually costs time. Working through a restoration like this, sometimes the restoration may come off. The restoration maybe might break between appointments. The restoration is leaking and the tooth remains infected in between appointments. So it may actually take longer rather than dismantling everything and making sure you do things right. So we've evaluated the tooth, we're maintaining an aseptic field. The next step is access. Now, root canals are generally quite small and the area we're working with is very difficult to see. One of the things that we can do to make things easier for ourselves is use magnification and use some form of direct light. You don't have to use a microscope. Good loops with good lighting will make your life a lot easier. Using long-shanked burrs specific for endodontic treatment allows us to see what we're doing as well. Locating canals is a lot easier if we understand the anatomical laws that relate to root canal anatomy. As a general rule, canals inside a tooth are symmetrical. They're generally located in the center of the tooth at the level of the CJ. They're generally located where the wall of the pulp chamber meets the floor of the pulp chamber. The floor of the pulp chamber has a different color. So if we remember all of those things, they're going to help us with locating canals. Once we've located the canals, the next most critical step in any root canal treatment procedure is gaining access to the apex. Not being able to gain access to the apex can have a negative outcome on the treatment that you're providing your patients. You can see these 2 cases here. In the case on the left, most people can notice that there's a broken file in that tooth. In the case on the right, you can see that the dentist hasn't been able to gain access to the apex. The outcome in both cases is the same. The patient has persistent infection because we weren't able to clean and disinfect the tooth to the anatomical apex. The way I access or gain access to the apex is using small hand files to negotiate the canal. I generally will use a 6, an 8 or a 10K file, but won't go any larger. These small instruments tend to be more flexible and less likely to gouge or create blockages within the root canal system. I generally will put a little curve in the file, which will help guide the file down the canal. And I never use files larger than 15 in most cases. Traditionally, we would estimate where we need to instrument a canal to, and then we would take a radiograph. There are some problems with taking radiographs. One is that the radiographic apex is not always the anatomical apex. So the position that we have to instrument and clean the canal to can vary by as much as 3 to 4 millimeters. So radiographs are generally an inaccurate way to assess working length determination. Radiographic interpretation is a problem. Obviously, angulation of radiographs, you can see over that one on the radiograph on the left, your working length looks fine. You take a coding and it's actually beyond the root apex. And this problem can be magnified, particularly in multi-rooted teeth or in posterior teeth where the bone is very thick. So I would recommend trying to take to determine your working length using electronic apex locators, which allow us to do that in real time. Now, earlier electronic apex locators were not very accurate. Modern apex locators are very accurate to within 0.5 millimeter in over 95% of teeth. They do take a little bit of practice and learning because there are certain clinical situations where they may be less accurate, such as teeth with an open apex, when there's restorations in place, if there's leakage or caries, which ultimately we should avoid, and certainly canals that join. So now that we've established our working length, we're going to start cleaning and disinfecting the tooth. The number one question I get from dentists when I do continuing education in Australia is, what is the best instrument for me to use and what do you use? And my answer to them is always the same. Do you like a Porsche or do you like a Ferrari? They're both good cars. They're both exotic sports cars. One will handle better, one will be more practical, one will cost less. It comes down to personal preference. And the same applies with rotary instruments. There are probably hundreds of different types of rotary instruments with different features. Some instrument systems will rely on one instrument to clean the canal. Some will rely on multiple instruments. Some will be heat treated. Some will be more flexible. Some will use a rotating motion. Some will use a reciprocating motion. They will all feel different. And it comes down to the practitioner's preference for which instrument system they use. What I would like you to consider is, should I be using hand instruments or should I be using rotary instruments? Okay, that's a big difference. If you're using hand instruments, you're probably doing your patients a disservice. Rotary instruments are far superior to hand instrumentation of a root canal system. And that's because they're made out of nickel titanium. Nickel titanium is much more flexible. It allows us to clean canals more predictably. The instruments, when they clean, remain more centered within the root canal system and they maintain the shape of the original root canal system, as well as the position of the apical foramen. And we know that if we change the shape of the root canal system during treatment, we're going to reduce the success rate of that treatment for our patients. We also have to keep in mind that when we instrument the inside of a tooth, realistically our instruments are cleaning about 30 to 40% of the actual root canal system. And that's because we know that the root canal systems are very complex. So you can see here there's a little 3D scan of the tooth before and after treatment. And you can see the green areas represent all the areas the instruments never cleaned. So we do rely on not only mechanical cleaning, but we also rely on chemical cleaning. During the mechanical phase of treatment, we also create what we call a smear layer, which is a layer of debris that contains organic and inorganic material that rubs up against the wall of the inside of the tooth, making disinfection more difficult. So the disinfectants that we really use to disinfect teeth usually are sodium hypochlorite, and that hasn't changed. We still use that and recommend that in Australia. And we combine that with EDTA, which removes the hydroxyapatite part of the debris. Even using these disinfectants, reaching the bacteria in all the irregularities within the root canal system is very difficult. So we do have to keep in mind how we can maximize our ability to get those disinfectants as far down into the tooth and into all of the irregularities inside the tooth. One way we can do that is using some of these auxiliary things that you can purchase. So using flexible irrigating tips that allow us to bring the irrigant closer to the apex. Using things like an activator like this that agitates the disinfectant and energizes it, allows that disinfectant to access further into those areas that are inaccessible with regular instrumentation. We can further disinfect teeth by using medicaments between appointments and doing treatment in multiple visits. So just coming finally to obturation. As we said at the start, obturating a root canal, the purpose of that is to stop new bacteria getting into the tooth and also to seal any bacteria that you may have left in the tooth and prevent that bacteria from gaining access to nutrients that will allow those bacteria to thrive. The benefit of using rotary instruments is that they generally create a consistent shape inside the root canal system. With hand instrumentation, the shape of the root canal system was much more irregular. So using rotary and night-eye systems, you're going to achieve the same shape for every tooth you clean that with that instrument. Most rotary instrument systems come with matched taper gutta-percha points. And so those points are much more closely matched to the shape that we've created during the cleaning process. They also come with paper points that make things easier. And I would say for the majority of teeth that you're treating, cold lateral condensation will be the technique that you would use in these cases. A lot of the time when canals are very small and narrow, you might not even need to use a lot of accessory points to fill those canals. Using a single cone can sometimes be sufficient. Nothing has changed in terms of using a sealer with gutta-percha. The purpose of the sealer is to fill the voids that the gutta-percha doesn't seal. An AH Plus or AH26 has been around for a really long time. It stood the test of time and shown to be very effective and a good sealer. New sealers that are available on the market, such as bioceramic, are also something that we could recommend. So just in conclusion, if we're going to look at whether it's root canal treatment, whether it's surgical treatment, whether it's orthodontic treatment, or anything we do in life, have a goal in the front of your mind. Come up with a strategy of how you're going to achieve that goal and put that strategy into action. In endodontics, and you're going to be successful if you understand the objective, if you become familiar with the strategy, and if you master the ability to execute the strategy. Thank you very much.
Cảm ơn bác sĩ Lước về trình bày rất là hay và thú vị. Xin kính mời bác sĩ chuyên khoa Trần Thị Thư, trưởng khoa trị Đội Nha, đi tra hiện trường. Thank you, Dr. Luke Bopler, for your amazing presentation. We would like to Dr. Trần Thị Thư, Head of Endodontic Department of the National Hospital of Odontology University, with a trophy, Dr. Luke Bopler.
Chairman to moderate the discussion with panelists.
Các bạn có thể đặt câu hỏi trực tiếp bằng tiếng Anh hay là bằng tiếng Việt, thì chúng tôi sẽ có ban phiên dịch ra tiếng Anh. Các bạn hãy đặt câu hỏi từ cái bài đầu tiên đến bài cuối cùng. Có ai có câu hỏi nào không ạ?
So hi. First of all, I just want to say thanks to all of your presentations. And I only have just one questions about the question is for Dr. Mark Farmer from Peer-to-Peer Department. So the question is, in a case I heard terms that is symmetrical tear, I guess, and it's quite new for me. So can you tell me more detail about that? Thank you.
Yes, during the destructive phase of the periodontitis, obviously you get destruction of the apparatus, so you'll lose lamina dura, periodontal ligament, and you can also have detachment of the cementum on the tooth surface. It's not very common; don't see it very often. I think I've had a couple of cases with Luke actually, but it's not a common occurrence at all. I couldn't put a percentage on how often it happens, but we do see it periodically.
Dạ. Cái tình trạng mà cemental tears tức là một cái dạng mà bong tách của cái lớp xi măng ở trên cái bề mặt, thì cái tình trạng này nó không có phổ biến. Tôi cũng gặp có một vài cây thôi, cho nên là chúng tôi gọi cái đó là cemental tears. Dạ.
Còn ai đặt câu hỏi không ạ?
I have a question for Dr. Mark Farmer too. In the presented clinical case of periodontitis, you have used Endogen, so could you provide more information about this material and its application for periodontal treatment? Thank you.
Sure. So Emdogain is used for what we consider to be true regeneration. So as we've been discussing this week, it's mainly used for the treatment of vertical bone defects around teeth and also more predictably class 2 furcations in lower molars. So it is being a true regenerative material. We're looking at forming bone, periodontal ligament, cementum, and it has been shown histologically to do that. Being an enamel matrix protein, it stimulates cells from the periodontal ligament to proliferate into the different cell types, and it also stimulates some growth factors as well. But a lot of research has been done into Emdogain, and they're still not 100% sure of all the functions that it has. But what we find with the Emdogain as well is healing is accelerated greatly. So, you see a patient for a post-op in 1 or 2 weeks, and you can't even see the incision lines. It's really, really good material.
Dạ, em xin phát dịch. Câu hỏi của hội thảo viên đó là trong một số ca lâm sàng thì thấy bác sĩ có sử dụng vật liệu là Emdogen, thì bác sĩ có thể cho biết là Emdogen thì đây là gì và cái ứng dụng nó như thế nào? Thì câu trả lời của bác sĩ Mark Farmer là Emdogen là một cái vật liệu mà sử dụng trong cái điều trị tái tạo mô nha chu. Thì những cái nghiên cứu về cái mô học thì đã có thể người ta đã chứng minh được là khi dùng cái vật liệu này thì nó sẽ tạo ra một cái gọi là tái tạo thực sự, những cái chứ không phải là cái kiểu lành thương, giống như là lành thương biểu mô băm nhân kéo dài thường gặp sau cái điều trị viêm nha chu. Thì thường là nó sẽ tạo ra được xương thật sự, xi măng thật sự và một ít cái xi măng là dây chằng xung quanh răng. Thì nó ứng dụng của nó là như những cái ca mà bác cho mọi người thấy thì nó sẽ ứng dụng trong những cái sang thương tiêu xương theo chiều dọc và rất là tốt khi mà điều trị cho cái sang thương vùng trễ ở độ 2 ở những cái răng khối lớn hàm dưới. Theo đánh giá của bác sĩ thì đây là một cái vật liệu rất là tốt sử dụng trong điều trị tái tạo mô nha chu. Yeah, xin.
Thank you, Dr. Mark Farmer. Tiếp theo xin mời bác sĩ Thái, khoa chỉnh nha.
Trước tiên thì xin cảm ơn cái bài trình của thầy Colette và của Newton Nash. Thì cái bài này cho chúng ta thấy rất là rõ về cái vấn đề mà điều trị chỉnh nha. Thì dĩ nhiên trong quá trình điều trị chỉnh nha nó sẽ xuất hiện một số cái gọi là một số cái không mong muốn, và đặc biệt là trong cái ca đầu tiên của mình thì cái chuyện mà không giữ được hai cái răng số 2 nó buộc lòng mình phải đổi kế hoạch. Thì trong cái bài này thì mình đã thấy được là cái cách mà người ta sử dụng kỹ thuật để tọt chân răng và điều trị được cái phần đó thì rất là ổn. Tuy nhiên muốn hỏi một câu hỏi với thầy Colette là Vì mình có dự đoán trước được cái vấn đề là nó sẽ bị nha chu ở hai cái răng số 2 hay không? Bởi vì cái răng số 3, mầm răng số 3 thì nó rất gần răng số 2. Riêng cái ca của Nash thì cái ca đó đúng là ác mộng của bác sĩ chỉnh nha nếu mà gặp phải. Bởi vì sau 6 tháng điều trị thì bắt đầu xuất hiện cái hiện tượng cắn hở. Thì cái này ngoài cái vấn đề mà điều trị cho bệnh nhân, cái phương pháp điều trị cho bệnh nhân, thì cái vấn đề quan trọng đôi khi nó là dính tới pháp lý nữa. Pháp lý ở đây có nghĩa là bệnh nhân rất là dễ có suy nghĩ là có thể là do cái điều trị chỉnh nha của mình mà có vấn đề ở khớp thái dương hàm. Vậy thì ngoài cái chuyện mà mình nói chuyện với bệnh nhân như thế nào để mà bệnh nhân có thể đồng ý cho một cái kế hoạch thứ 2, thứ 3 của mình mà người ta vẫn vui vẻ chấp nhận mà không ảnh hưởng tới cái quá trình điều trị của mình, cái cách mà mình trao đổi với bệnh nhân để người ta chấp nhận khi mà có cái vấn đề xảy ra. Bởi vì ca này ngoài cái chuyện mà chỉnh nha xong rồi mình còn phải phẫu thuật, rồi mình có nhổ răng mình chỉnh lần 2, lần 3 nữa thì cảm thấy nó rất là phức tạp với cách trao đổi với người bệnh nhân. Xin hết rồi.
Firstly, I would like to thank you for the presentation. And Dr. Thai has two questions. The first one is about the periodontic problem. Is there any periodontic concerns for the canines when you have to remove the number, the tooth 1, 2, and 2, 2? Because as you can see, the canines are very close to the roots of the 1, 2, and 2, 2. And for the second question, he would like to ask, how did you talk to the patient? Because did the patient wonder if her problem is due to the orthodontic treatment? And how did you talk to her and for her to agree with the new treatment? Because the new treatment is quite complicated, involving extraction and a two-phase surgery. Thank you.
Thank you. I might start at the end of the question and work backwards. First, in terms of the patient and the patient's attitude, from the very start, I spent quite a bit of time discussing the treatment plan with the mother and the patient. So they were aware of the difficulties that were involved in the presentation. So before we started treatment, there had been some involved discussion, and I also got a periodontist involved as well. So when we started out, and I try to, with most of my treatments, I have a plan A and plan B, because you don't know if plan A is going to be successful, and you have to have an alternative. So what if the non-extraction treatment's not going well, you extract. So you have plan A and plan B. I try to inform the patients that we'll be doing this, and then we may have to consider another option, see how things are going. Sometimes there are surprises during treatment, but in this case, there was no great surprise for the patient because I kept them informed the whole time. And there were visits to the periodontist, and the periodontist and I, who I know very well, and Mark would know quite well as to Jason Bloom, who was the periodontist involved. But we had a number of conversations on the telephone, which I then, if there was something after a conversation, I would ring up the mother that night and tell her about what had been discussed. So I think at the end, the mother actually thanked me quite a lot. She said that, well, without trying to sound self-important, she actually said she was so grateful that she had come to see me because she felt that she had the best treatment for her daughter. Going back, of course, the periodontal issues and putting a 1-3 and 2-3 in place is always, difficult and depends where the canines are coming from. And every orthodontist and oral surgeon and periodontist have had difficulties with the gingival health of palatally positioned and laterally positioned canines. In terms of where that canine started and where we ended up travelling and finishing it, And although it had a slightly longer clinical crown and all the potential problems that could have occurred, I think it actually turned out pretty well. But it's always a concern, and actually I was talking to Dr. Besley about this yesterday. I think we're talking, Bill, about apically repositioned flaps and canines and getting tissues in the right spot. But the periodontal health of ectopic canines is always a concern, sometimes unpredictable. And I have been embarrassed a couple of times with lower canines actually, where the lower canines have been labally positioned and have brought them in, and I've lost a lot of tissue attachment, and I don't know why, because I haven't done anything different to what I've done in another patient. And is it just a genetic biotype, genetic responses to the mechanics? It'd be great if everything was predictable, but we're dealing with wide individual variations a lot of the time. Does that answer the question? Is there any part of the question I haven't addressed? Sorry? Oh, it's got to be translated. I'm sorry for the translator.
Dạ thầy Dr. Colette trả lời là trong suốt quá trình điều trị thì Dr. Colette luôn trao đổi với lại bác sĩ Nha Chu, và mỗi khi mà có vấn đề thì đều nói chuyện với mẹ của bệnh nhân trước và trong suốt quá trình điều trị. Còn việc về vấn đề Nha Chu của răng ba mà một ngầm thì đó luôn luôn là một cái mối bận tâm trong cái việc mà mình kéo răng ngầm, thì cái này là không thể tránh khỏi được và đương nhiên là mình sẽ gặp. Và thầy nói là trong cái sự nghiệp của thầy đã gặp rất nhiều trường hợp mà có nhiều chuyện xảy ra ngoài dự kiến, nhưng mà nhờ vào việc lúc nào cũng trao đổi với bác sĩ Nha Chu và trao đổi với bệnh nhân mà sẽ tránh được những cái rắc rối và những cái kết quả không mong muốn mà bệnh nhân mà mình không có trao đổi trước với bệnh nhân.
So, for my case, I'm going to keep it short for the translator. But you can have difficult cases and you can have difficult patients. I would prefer to have a difficult case over a difficult patient. We were very lucky that this patient was very, very nice. That said, the way we managed it, we made sure we were always honest with the patient. We made sure that we were united as a team. So if I didn't know something, I wouldn't say anything to the patient. If the surgeon didn't know, they wouldn't say that either. We would make sure we presented something united together, and we prioritized that patient. We made sure that she was looked after. And sometimes the hardest thing to say to a patient is, I'm sorry, we don't know. We actually don't know why the condyles resolve. There are risk factors, but we don't know. Likewise, it's very hard to say, I'm sorry, we can't actually treat you now. Because if we do, it's going to get worse. So a lot of it was coming together not only as a team for the planning, but as a team for those discussions, presenting a united plan, united priority, and making the patient feel special, because she was special to us. She was lovely. But even if she wasn't, she needs to be special to you, because that is your priority. The patient is your priority. So you need to express that. With that, most people are quite happy. They understand that there are some things that are unknown, and it's being honest about it. Coming together and working hard to come up with a plan for them.
Thì mình trong cái quá trình điều trị của mình sẽ gặp những ca khó hoặc là bệnh nhân khó. Bản thân tôi thì tôi thà gặp ca khó còn hơn là bệnh nhân khó. Trường hợp này thì tôi rất may mắn vì bệnh nhân rất là dễ thương.
Thì để trả lời câu hỏi của bác sĩ Thái thì tôi với lại đội ngũ bác sĩ phẫu thuật luôn luôn có bàn bạc trước và thống nhất câu trả lời. Vì vậy khi mà chúng tôi đưa ra câu trả lời hay là trao đổi với bệnh nhân thì chúng ta sẽ không có mâu thuẫn với nhau. Tôi sẽ không nói ra những điều mà tôi không chắc chắn và bác sĩ phẫu thuật cũng sẽ không trao đổi với bệnh nhân về những điều mà bác sĩ không chắc chắn. Thì từ đó mình có thể thấy được là bệnh nhân sẽ cảm thấy họ được quan tâm, họ được chăm sóc. Thì khi đó thì họ sẽ mình sẽ dễ trao đổi với họ hơn.
Thank you, Dr. Tony Collett and Dr. Linton Nas. Còn ai còn câu hỏi khác nữa không ạ? Mời bác sĩ Minh Hồng.
Xin phép cho hỏi một câu của bác sĩ Resilin, đó là sau khi mà điều trị ung thư thì các vấn đề về mặt miệng hay xảy ra và nó bị đau, thì xin bác sĩ giải thích rõ thêm một số cái điều trị cho các trường hợp bị đau lên mặt miệng sau khi mà điều trị ung thư.
Hi, Dr. Celine. Dr. Hồng would like to know about the mucositis and oral pain management. It would mean that you can quickly summarize about the systemic and topical anesthesia in that case. Yeah, some kind of training, for example.
Yeah, sure. Yeah, so the difficulty with mucositis is that it can be extremely painful, to the point where some patients are not able to eat and drink anymore at all, and sometimes end up with a nasogastric tube, a tube to get food and drink through their nose. The best things to try and manage the symptoms, a lot of patients need systemic analgesia, and usually we'll do that in combination with the medical team, because sometimes they may already be on one type of painkiller, and so they might need another or a different dose. Sometimes that can involve quite strong painkillers, like opiates as well. Oxycodone would be an example of that. For topical things, sometimes patients will use viscous lignocaine, so like a gel to go in the mouth, and you can mix that with other solutions. There's something that's used to treat reflux disease in Australia that coats the tissues. If you mix those two things together, then it coats the tissue with the lignocaine to help with pain relief. Other things, for example, you have to be careful because the patient might not have an active immune system. But ice often, cryotherapy, just very cold, and the mouth can help with symptoms as well. You just have to be careful where the ice came from because you don't want to give the patient an infection. There are other sort of mouthwashes. You can get like a special supersaturated calcium phosphate mouthwash as well, and that can help with symptoms too. But some patients, unfortunately, will not respond necessarily very well to these things, but you often have to reassure them that usually we'll go through a period and then get better as the patient gets better as well.
Thank you. Dạ, em xin được phép dịch lại câu trả lời của bác cố viên. Thì Dr. Celine nói rằng một số trường hợp mà bệnh nhân mà sau khi điều trị ung thư thì bị viêm miệng rất là nặng và bệnh nhân rất là đau, rất là khó khăn trong ăn uống, thậm chí một số trường hợp có thể sử dụng cái ống thông mũi với dạ dày để có thể truyền dinh dưỡng. Thì trong những trường hợp đó thì thường là phải sử dụng cái thuốc giảm đau mà đường uống, thì sẽ tham khảo với bác sĩ đa khoa người ta cho. Còn thậm chí một số trường hợp có thể dùng những cái dòng opioid. Về phía mà giảm đau mà những cái thuốc tại chỗ thì sẽ sử dụng cái lidocaine dạng nhớt trộn chung với lại cái thuốc giống như là tương tự như là thuốc chống trào ngược dạ dày của mình, giống như thuốc tê vậy đó, xong rồi sẽ trộn lại và cho bệnh nhân xúc ngậm cái đó một lúc rồi xong rồi nuốt vô thì sẽ có tác dụng giảm đau cho bệnh nhân. Một số trường hợp mà khi mà cái hệ thống miễn dịch của bệnh nhân không có quá nguy hiểm thì cũng có thể dùng giảm đau như dạng đá cho bệnh nhân ngậm, nhưng mà cái đó phải cẩn thận, tại vì đá thì một số nguồn mình phải cẩn thận là cái đá phải sạch chứ không thôi là sẽ gây nhiễm cho bệnh nhân do bệnh nhân là đang có ức chế giảm miễn dịch. Dạ, đó là một số điều trị có thể giúp đỡ cho bệnh nhân. Dạ, xin cảm ơn.
Thank you, Dr. Grigory Rivasili. Còn ai có câu hỏi khác nữa không?
Kính thưa quý lãnh đạo, quý khách mời và toàn thể hội thảo viên, chương trình hội thảo cá nhân hóa kế hoạch điều trị trong nha khoa xin được khép lại tại đây. Ban tổ chức hội thảo xin chân thành cảm ơn quý lãnh đạo, các vị khách mời và toàn thể hội thảo viên đã dành thời gian quý báu đến tham dự hội thảo. Kính chúc quý vị một buổi chiều tối vui vẻ. Xin cảm ơn và hẹn gặp lại. Dear leaders,